Hi, this is Dr. Akhtar. In the last lecture, we discussed some non-neoplastic lesions such as chalazion, xanthelasma, dermite, and other. Uh, Now, some other non-neoplastic lesions of the eyelid. Uh, Today's topic is benign epidermal tumors, in which the first one is squamous cell papilloma. So, squamous cell papilloma histopathology in all clinical types is similar, showing finger-like projections. Here you can see fibrovascular connective tissue covered by irregular acanthotic hyperkeratotic squamous epithelium. Squamous cell papilloma, it is a very common benign epithelial tumor. Very common benign epithelial tumor. And there is a range of clinical appearance, including narrow-based pedunculated or skin tag. Here you can see pedunculated skin tag. Pink broad-based, here you can see pink broad-based sessile, and here you can see whitish thread-like filiform hyperkeratotic lesions similar to a cutaneous horn. This is cutaneous horn. So the incidence increases with age. Some cases result from human papillomavirus infection. Treatment usually involves simple excision, but other options include cryotherapy and laser or chemical ablation. So this is squamous cell papilloma. Another one is seborrheic keratosis. Their histopathology shows expansion of the squamous epithelium of the epidermis by proliferating basal cells, sometimes with keratin-filled horns or cystic inclusions. Here you can see seborrheic keratosis, also known as basal cell papilloma. The previous was squamous cell, and this is known as basal cell papilloma. This is an extremely common, slowly growing lesion found on the face, trunk, and extremities of elderly individuals. Discrete light to dark brown plaque with a friable and greasy verrucous surface, stuck on appearance. This is stuck on appearance. They are frequently numerous, and the differential diagnoses include pigmented basal cell carcinoma, nevus, and melanoma. Treatment involves shave biopsy, occasionally simple excision, electrodesiccation with curettage, laser ablation, cryotherapy with liquid nitrogen, and chemical peeling. So this is seborrheic keratosis or basal cell papilloma. Another one is actinic keratosis. The histopathology shows irregular dysplastic epidermis with hyperkeratosis, parakeratosis, cutaneous horn formation. Actinic keratosis, also known as solar keratosis, senile keratosis. It is a common slow growing lesion. It rarely develops on the eyelids. It typically affects elderly fair skinned individuals and areas of sun damaged skin such as forehead and backs of the hands, and appear as hyperkeratotic plaque with distinct borders and a scaly surface that may become fissured. Occasionally, the lesion is nodular with a wart-like and may give rise to cutaneous horn. It has potential, though low, for transformation into squamous cell carcinoma. Treatment involves biopsy followed by excision or cryotherapy. So these were benign epidermal tumors. Now benign pigmented lesions. In benign pigmented lesion, the first one is freckle, also known as epilis, plural is epilytes. It is a small, generally 1 to 5 millimeter, brown macule due to increased melanin in the epidermal basal cell layer. Typically found in the sun-exposed skin. The number of freckles vary with the level of sun exposure, and it can sometimes regress completely. Histopathology shows hyperpigmentation in the basal layer of the epidermis with normal melanocyte population. So there is normal melanocyte population. Another benign pigmented lesion is congenital melanocytic nevus. Congenital nevi, they are uncommon. Histologically resemble their acquired counterparts. So histologically they resemble the acquired. They are usually small and of uniform color. Rare variants include a kissing or split nevus that involves the upper and lower eyelid. Here you can see. May occasionally contain numerous hairs. Here you can see a very large lesion covering an extensive area of the body, giant hairy nevus. Large lesions have the potential for malignant transformation. So 15% of the large lesions, they convert to malignant lesions. Treatment, if necessary, involves complete surgical excision. Now, acquired melanocytic nevus. The clinical appearance and potential for malignant transformation is determined by the histological location. The first one is junctional nevus. This is junctional. They occur in young individual, uniformly brown macule or plaque. The nevus cells are located at junction of the epidermis and dermis. They have a low potential for malignant transformation. Low potential. Another type of acquired melanocytic nevus is compound nevus. Compound nevus occurs in middle age. There is raised papular lesion and the shadow of pigment varies from light tan to dark brown. Dark brown. So here you can see in the picture, this is compound nevus. There is raised papular lesion and relatively it is uniform throughout. Nevus cells extend from the epidermis into the dermis. It has a low malignant potential related to the junctional component. So this one is junctional nevus, this one is compound nevus. And the third type of acquired melanocytic nevus is intradermal nevus. This is intradermal nevus. It is the most common. It typically occurs in older patients. It is a papillomatous lesion with little or no pigmentation. And histologically, nevus cells are confined to the dermis and no malignant potential. So these were the pigmented lesions, benign pigmented lesions of the eyelid. Now benign adnexal tumors. The first one is syringomas. These are the syringomas. They are benign proliferations arising from eccrine sweat glands. They are characterized by small papules that are often multiple and bilateral. Another one is benign adnexal tumor is pilometricoma. This is pilometricoma, also known as pilometrisoma, also known as calcifying epithelioma of Malherbe. It is derived from germinal matrix cells of the hair bulb and the commonest hair follicle proliferation seen by ophthalmologists. It affects children and young adults. It is more common in females. Clinically, it appears as mobile, purplish dermal nodule. So this is, here you can see in the picture. It may have a hard consistency due to calcification, which is usually present, and there is foreign body giant cell reaction. Malignant change is rare. It is usually removed surgically. Other less common disorders of the hair follicle proliferation include trichofolliculoma, trichoepithelioma, and trichilomoma. So this is pilometricoma, and it is the derived from the germinal matrix cells of the hair bulb, hair follicle proliferation. There are some others benign tumors such as capillary hemangioma, which everyone of you will have seen. It is also known as strawberry nevus, and it is one of the most common tumors of infancy. It is 3 times as common in girls as boys, and there is proliferation of varying sized vascular channels. Histologically, there is proliferation of varying sized vascular channels in the dermis and subcutaneous tissue, and it presents shortly after birth. It is unilateral and raised bright red lesion. Here you can see unilateral raised bright red lesion, usually in the upper lid. A deeper lesion appears purplish. Here you can see a deeper lesion. The lesion blanches on pressure and may swell on crying. Ptosis is frequent and there may orbital extension. In chapter 4 we will study that. Occasionally the lesion may involve the skin of the face, and some patients have strawberry nevi on other parts of the body. Now it is important to be aware of an association between multiple cutaneous lesions and visceral hemangiomas, and to consider systemic assessment in appropriate cases. Treatment will be described in chapter 4. So a capillary hemangioma, it can be easily and successfully treated by a regular application of topical beta blocker to the affected lesion. So this is capillary hemangioma. This is the most common tumor in infancy. Another benign tumor is port wine stain, also known as nevus flammeus, and it is a congenital malformation of the vessel within the superficial dermis. Histopathologically, is vascular spaces varying caliber separated by thin fibrous septae. Here you can see thin fibrous septae. 10% have associated ocular or CNS involvement, including Sturge-Weber and other syndromes, which we will discuss shortly. Diagnosis is sharply demarcated soft pink patch that does not blanch with pressure. So the last topic, capillary hemangioma, it was blanching with pressure, and here this portwine stain do not blanch with pressure. And most frequently located in the face, and usually it is unilateral and tends to be aligned with the skin area supplied by one or more divisions of the trigeminal nerve. Here you can see trigeminal nerve, dermatome. Darkening to red or purple take place with age and commonly associated soft tissue hypertrophy. Bleeding may occur from focal overlying lobulation. Treatment is with laser pulse dye. It effectively decreases skin discoloration, particularly if undertaken early. Topical preparation are imiquimod and rapamycin. Imiquimod and rapamycin alone or with adjuvant laser. Let's show promise. Soft tissue debulking is used in a number of cases, in a small number of cases. Another important thing is screening for glaucoma. It should begin in infancy. And another important thing is systemic investigations in some patients, particularly those with a lesion of the lumbar area. So the association is Sturge-Weber syndrome, also known as encephalo-trigeminal angiomatosis. So it is congenital sporadic pacomatosis. The signs and symptoms are portwine stain, which extend over the area of the trigeminal nerve. There is leptomeningeal hemangioma, ipsilateral parietal or occipital region involvement, contralateral seizures, hemiparesis, hemianopia. Ocular features, there is glaucoma. So important thing is glaucoma, hemangioma and iris heterochromia, diffuse choroidal hemangioma. Next topic is pyogenic granuloma. This is pyogenic granuloma. It is a rapidly growing vascularized proliferation of the granulation tissue and usually antedated by surgery, trauma, infection. Some cases are idiopathic. This is painful and rapidly growing. There is vascular granulation, polypoidal lesion. It may bleed following relatively trivial trauma. Cutaneous lesions should be excised, and conjunctival pyogenic granuloma will be discussed in chapter number 6. Another one is neurofibroma. So the cutaneous neurofibromas, they are benign nerve tumors. They are usually nodular and pedunculated. It can be found anywhere on the skin. An isolated neurofibroma is common in normal individuals, but if multiple lesions are present, neurofibromatosis should be excluded. Plexiform neurofibromas present in childhood and is a manifestation of neurofibromatosis type 1. There is S-shaped deformity of the upper lid. Here you can see S-shaped deformity. Treatment of solitary lesions, they involve simple excision, but removal of the more diffuse plexiform lesion is difficult. Thank you so much.